Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral blocked ears. And I suspect that their right ear, they had a grade 1 keratosis obturans. So this is their left ear. Their right ear is the more complex procedure like the two. So I've decided to play that after this, their left ear. And here, I'm just using the right ear pick. As soon as I went with the suction probe against the wax and dead skin plug, I knew it was too solid. There was no surface suction grip there. So I just used the right ear pick to good effect. As you can see, I've embedded the taper tip into the core of this plug of wax and dead skin and slowly brought it forwards. And the ear pick did assist in their right ear, which is far more complex. So do stay tuned for that. So I'm just removing this from the ear. So I used the right ear pick with another patient who attended the other day with an emergency appointment to really good effect. So I'll try and upload that video perhaps tomorrow or later on in the week. So the eardrum's nice and healthy. It's just got this dry skin around the periphery. So I'm just going to peel away some of this skin, the bigger lumps and chunks anyway. Just going to be careful of clarineting. So a lot of people ask what clarineting is, and it's when you suction dead skin, the skin starts flapping at the tip of the suction probe, and it emits a very loud, high-frequency squeal. So that's what we call clarineting. So whenever you get clarineting, you want to minimize that or alleviate it. So reverting to a fine end, for example, like I'm doing here, is one method, and sometimes using manual instruments. The third option is just to leave any wax or skin that's clarineting. It's not worth sometimes trying to remove that. You'd rather have reduced noise levels and a bit of wax or skin remaining than for it to clarinet. So just peeling some skin off the roof of the ear canal here, so it's quite dry. So they do have some form of skin conditioning, because with keratosis obturans, essentially that's what keratosis obturans is. It's a buildup of dead skin, and it normally accumulates very deep in the ear, and that's exactly what I think they've got in their right ear. But you can get different types of keratosis obturans. So some of the more common types of keratosis obturans is when you get these ribbons, these layers of interconnected dead skin cells. So they've almost form like an onion structure, so we call it a lamella structure. And when you've got that lamella structure, the skin sometimes is a bit damp because of the humidity that is created in between these layers. But sometimes you can get a keratosis obturans like this, which is rock solid, and this is like a stone. So I put some drops in straight away. And there is some remodeling of the ear canal. So what I mean by remodeling, you'll see more at the floor of the ear canal and also around the periphery, there is some widening, and that's a hallmark of keratosis obturans. So sitting on the surface of the bone, which constitutes the inner 2/3 of the ear canal, is specialized bone cells called osteoclasts, and they perform a procedure called bony resorption. So they breaks down the bones into its minerals and tissues, and it redistributes the minerals and tissues into the bloodstream. So it's used by other specialist cells that sit on the surface of the bone called osteoblasts, and osteoblasts form new bone. So all the bone in our body is continuously rejuvenating itself. So the surface of the bone, it's broken down, and you have new bone formation by osteoblasts. And one of the advantages of this process is that if you have got some bacteria, for example, on the surface of the bone, when that, due to the process of bony resorption performed by the osteoclasts, this bacteria is taken off the surface of the bone and it's replaced by healthier, newly formed bone. So with keratosis obturans, because this plug of dead skin is compressing against the canal wall, it initiates the osteoclasts, and we can get some bony remodeling, so which is a changing of the shape. And because the osteoclasts are more active than the osteoblasts, you tend to find that it widens. The bone very rarely kind of rejuvenates. It can do, potentially. The osteoblasts later on can form new bone where the bone is missing, but normally because of the hyperactivity of the osteoclast caused by the compression of the keratin plug up against the canal wall, up against the bone. It initiates the osteoclast more. So here I'm going to use a combination of suction. I've used the right ear pick. Although the right ear pick didn't necessarily remove it, it did break away some of this keratin plug. And I'm going to use some forceps in a moment. This was quite painful for the patient, this procedure. There were a bit of pain upon attending. And you can see why, because this plug is right up against the eardrum and also the bony part of the ear canal. And the bony part of the ear canal is highly sensitive. So here's when I just decided to use the forceps. There's a bit of a space at the bottom, and again, this was a bit uncomfortable for the patient. And I got a decent grip, but this plug is so embedded that it just wasn't going to come away, even with forceps. So I think I'm going to use the right ear pick again in a moment. I'm going to glide it inferiorly where there's a little gap there to see if I can lift it up and away, and it did somewhat. But another hallmark of keratosis obstruans, you have this periphery silvery white matrix, which you can see here. So that's freshly dead skin. That's semi-detached itself from the canal wall. And that peripheral white matrix will eventually, if this was not removed, it will slowly get pushed into the center of this keratin plug, and it will darken in the process, so it will oxidize, and then you'll have another layer of freshly shed skin that forms the white peripheral matrix. So you can see the pick is slowly bring this out, but I'm just going to suction some of the fragments of this dead skin caused by the ear pick, and I'm just going to try the suction again. Because I've broken it up a little bit, it's good to reduce the size of this plug. So by reducing the size of it, hopefully we can wriggle it out. So you can see again this peripheral matrix, which I'm just trying to remove, and that not only makes the plug smaller, but it helps to detach the plug from the canal wall. So that silvery matrix that I just removed, it was still semi-adherent to the canal wall, and it was enveloped around the wax plug. So it's almost like double-sided sticky tape. And by peeling that away, it helps to mobilize this plug. And you'll see afterwards how this patient's ear canal has widened, especially at the floor. So again, there was a substantial piece of dead skin removed, it was still reducing the size of this. So I'm just going to go to the top. So this patient normally attends every 18 months, but I've just advised them to attend every year after today's procedure, because it's a bit trickier than usual to remove. And with keratosis obstruans, one of the treatments is just to regular debridement, so we just clean the ear on a regular basis to keep on top of it. So you can't see it at the moment, but on the right hand side, that wax plug, that part of the ear canal is wider and you can't see it, but the plug's filling that area, and so hence why it's difficult to remove. So just by putting some oil in, I'm trying to provide some lubrication, similar to when you if you ever get a ring stuck in your finger and you just apply some washing up liquid or soap around your finger to provide some lubrication to try and tease the ring out of your finger. I'm using the oil in the same way to try to tease this keratin plug. And what I want to do is lift it up and to the left, because it's trapped on the right. I want to angle this to the left so we can kind of remove it from that anterior recess. So I've got a decent suction grip here, and I'm lifting it up and then to the left. I can feel it slowly coming away. I don't want to come away too quickly with the suction tip, because I've got a good kind of airtight seal here which maximizes the suction power. If I come away too soon, I'm going to lose that kind of airtight seal and lose suction power. And I feel I'm out of the anterior recess, and I'm just slowly, you can see these little wriggle movements, which always helps. So we're near the entrance now. There we are. So managed to reveal that the patient. I'm greatly appreciative and very relieved. You can see to the right, there's a big anterior recess, and also to the floor of the ear canal, there's a bit of a widening there. It's also kind of widening around the edges as well. The plug to the left is of their right ear, and to the right is the left ear. Well, I hope you enjoyed that video, guys.